I think in the community, because there's not a multidisciplinary tumor board in every hospital, or physicians don't have time to go to multidisciplinary tumor boards, it really is on the dermatologist to really set up consults for these patients, especially if this is a recurrent lesion in a radiated area, or it's a large lesion, or it's in an area that's going to require a very large disfiguring surgery. Again, we can operate, but what are we going to leave the patient looking like? And so I think, yes, certainly you can have a consult that goes to the head and neck surgeon or the medical oncologist. So this way there's a unified plan moving forward, because some patients may have a partial response where the tumor will shrink up and you need the surgeon. So it's always good to get everybody on board in the beginning and keep those open lines of communication so that you can easily move the patient from your medical therapy over to get a surgical procedure if that's the right thing to do. I think patients need to be informed as to what are the risks and benefits of each modality. So what are the risks of radiation and what are the potential benefits? What are the risks of surgery? What am I going to look like when this is done? Am I well enough to undergo this degree of a procedure without having another complication like a stroke or a heart attack in the post-op phase? Can the patient receive systemic immunotherapy? The answer is not always universally yes. We run into a big issue with patients who have undergone organ transplant. Organ transplant patients are notorious for having multiple invasive squamous cell cancers. However, we know that by giving these patients anti-PD-1 therapy, such as cemiplimab, they're going to reject their organ. So if a patient gets sent to me and has a liver transplant or a kidney transplant and they have locally advanced squamous cell, I'm not the right person for them. I'm going to refer them back either to the surgeon or the radiation oncologist because I need to preserve the transplanted organ. For this woman, I don't think that surgery is the right option because she's got such extensive perineural invasion, such a poorly differentiated squamous cell in a very difficult area under her eye. Can it be done? Sure. Do I think it's the right thing to do? Probably not. Radiation, on the other hand, is going to cause her potential visual issues. So I don't think that that's really a feasible thing to do either. Can she get immunotherapy with cemiplimab? My answer is yes. Am I going to exacerbate her rheumatoid arthritis? You bet I am. And so I'm going to need to really communicate beforehand with her rheumatologist to make sure that we work together to keep her comfortable and treat her cancer at the same time. I would not be excited about giving her the older conventional treatments such as EGFR receptor inhibitors or chemotherapy, again, because it doesn't provide her with durability, and we're looking to really get rid of this for her because it's a locally advanced tumor.